American Laryngological Association, that's ALA. Yeah. And the American Bronchoesophageal Association. A huge round of applause for her, please.
Thank you so much. Thank
She
you
is also, I mean, actually, the resume is even far larger than this. Like, she has been the chief editor of Textbook of Laryngology, a gold medalist in Junior Consultant Award, and in the previous session, Jaipur video session conducted by AOI, and she's received many other awards. And she's the editor of a Journal of British Laryngology Association, and so on and so forth. There's no end. She has more than 100 publications. Welcome, Dr. Nupur. Thank you so much for being here despite an early morning flight to Montreal.
It's not tomorrow morning, thankfully.
Oh,
but
okay.
Thank you so much for this very kind invitation. And with your permission, should I start the talk?
Yes, please.
Okay,
yes,
lovely.
please.
Thank you. It's really an honor, actually, for me to be invited. And I'm so delighted to be here amongst all of you all to talk about this very interesting topic, really. The topic is trans voice surgery. And why I have called it feminizing voice surgery is that the trans men don't typically need a surgery, and I'll talk about that. So it's really the trans women who need a surgery. So therefore, I'm calling it feminizing voice surgeries. If at any time you can't see the video or hear the audio, please do just give me a heads up. So I'm just going to move ahead. I work in Bombay Hospital, and thank you so much for that very generous and kind introduction. And I want to just share with all of you all that the International Association of Trans Voice Surgeons was a group that got formed in Berlin in 2022 towards the end of the pandemic. So that was my first international trip post-pandemic, so to say. And it's an association formed by 13 people originally, people who are interested in trans voice surgery. And this association is very much growing. So this is the website of the International Association of Trans Voice Surgeons. And we are very happy to have new members. So this is, you can check the website out and see what the criteria are to become part of the association. What are the indications of feminizing voice surgery? Typically, a male to female patient undergoing transgender surgery, so a trans woman. But sometimes you have female patients who have a persistently low-pitched voice despite speech therapy, androphonia. They can also be considered for these kind of surgeries. And I'm sure all of us know this, but I just want to talk about the fact that our frequency or our pitch is a very fundamental character, which gives away whether we are females or males, because typically a male will have a frequency in the range of 100 to 140, and females are more in the range of 200 to 230. So basically, it's almost an octave higher for females, which is 12 notes. So if you were to see it on the piano, it's something like this. And that's what we want to achieve. We want to get an octave higher, ideally, when we do a trans voice surgery. So how do we do this? Because pitch is the most important character, I said. So how do we play around with the pitch? So pitch, which is the same thing as frequency, which is how many times a vocal fold vibrates in 1 second, that is your frequency or your pitch, is directly related to the tension of your vocal folds. It's also directly related to the stiffness and the subglottal pressures. But it is inversely related to the mass and the length of the vocal fold. So we can do various surgeries to increase our pitch by increasing tension or increasing stiffness or decreasing the length of the vocal fold, which is going to be the highlight of my talk, the Wendler's glottoplasty, where you're decreasing the length or decreasing the mass. Sometimes can add on a little bit of effect. And these surgeries can be done either endoscopically as phonomicrosurgery or as an open laryngeal framework surgery. So the various surgeries which are described are the cricothyroid approximation, anterior web formation, decreasing the mass, which is known as laser-assisted mass reduction, or a LAVA, which is a laser-assisted voice adjustment. Thyroid elevation will help your resonance, and something known as a feminizing laryngoplasty. And we are going to talk about many of these. So what does each surgery do? The typical surgery which we were doing maybe 20 years ago, I myself was doing, was cricothyroid approximation, where you're basically increasing the tension of the vocal folds. Now, what most of the surgeons who are doing this feminizing voice surgery, now most of them are performing Wendler's glottoplasty, in which you're decreasing the length of the membranous vocal fold. One can also increase stiffness or decrease mass by using a laser and either just making incisions on the epithelium of the vocal fold laterally, and you can go deeper and remove a lot of mass, then that is known as laser-assisted mass reduction. And a femoral surgery will work on all these three: increase tension, decrease length, increase stiffness. So it acts at many levels. And Wendler surgery, LAVA and LAMR are phonomicrosurgeries, and the cricothyroid approximation and the femoral, which I'll talk about also, are the laryngeal framework surgeries. So to just touch upon laryngeal framework surgery, Pear described it in 1915 actually, but it got popularized, of course, by Professor Ishiki in 1974, who described the various types of framework surgeries, which was type 1, 2, 3, 4, and arytenoid adduction. And then the European Laryngology Association has defined, sort of redefined or renamed it as a laryngoplasty, where it is named more by what it achieves rather than type 1, 2, 3. It's like a type 1 or arytenoid adduction is like a approximation laryngoplasty, because that's what you're doing, approximating or medializing. So what would be the feminizing surgery then? The tensioning laryngoplasty. That would be the feminizing surgery. So what does this cricothyroid approximation achieve? Basically, you are trying to eliminate completely the cricothyroid space by taking 4 sutures from the cricoid to the thyroid cartilage, so as to replicate the action of the cricothyroid muscle, the 2 medial and the 2 lateral muscles, bellies. And it's felt that an elevation of a pitch elevation of 0.15 to 0.9 semitones is possibly achieved with every 1 millimeter of approximation. But it's, 0.1 to 0.9 is so variable because the surgery itself is very unpredictable and variable. Sometimes it can happen that after the surgery, there is no pitch increase whatsoever. Sometimes it can happen that there is a massive pitch increase in terms of the voice, almost becomes like a Donald Duck kind of voice. But over some time, these sutures open up, unfortunately, almost 30-40% of the times, and you have a pitch drop almost to the pre-surgical level. So this is the reason why it has been abandoned in many places. And including my center, we don't do this surgery either because of these basic problems that we run into. And every surgery will have its pros and cons. So there are advantages in terms of it's in local anesthesia. You're not actually doing anything to the vocal folds. So if tomorrow you want to do something to the vocal folds, you've not touched it. And it can be coupled along with a thyroid shave, which we'll talk about also. And since you're hearing the voice, you can try to fine tune it. Now, this is easy to say, but how can you fine tune it if there's no pitch increase happening? That becomes a problem. So the advantages are the unpredictable results, that falsetto, very high pitched Donald Duck voice, the drop in the pitch, which I mentioned. Also, very important problem is a lock of the pitch. The pitch gets locked because a patient then can't increase or decrease the pitch. So there's no modulation possible anymore because it's like the cricothyroid is constantly in action. When the sutures cut through, then there's an issue. And no trans woman would like to have a scar in the neck. And that's what this surgery really entails. And if you don't do a tracheal shave or an Adam's apple shave, then your Adam's apple is going to get even more prominent because, you're bringing the cricoid to the thyroid. So these are the cons of the surgery. So let's now talk about Wendler's glottoplasty, which is something most of us are doing, and I've been doing now for the last 15 years in Bombay Hospital. That's Professor Wendler, who I had the honor to meet in Berlin. This surgery can be done as an endoscopic suture glottoplasty or with a laser. So you may or may not use the laser. The laser is just a tool. What you're trying to achieve basically in this surgery is you're trying to shorten the length of the membranous vocal fold by 50%. If you do less than that, you don't achieve what you want. If you do more than that, you have the danger of dyspnea on exertion. So typically, when patients come to our hospital, I'll tell you, the experience in India may be different from the experience in the West. All our patients in our voice clinic have typically already had the feminizing genitoplasty, breast augmentation, hormonal therapy, a psychological evaluation, very often facial dental treatment. And most of them have come just for surgery through YouTube or Facebook or Instagram. And they just want the surgery and they want to be gone. So they want a lot of anonymity also. They are not amenable to voice modulation, and there are reasons for that. Most of them have also depleted their financial resources and they don't have family support. So these are things which come with this group of individuals, at least in my practice. As far as the surgery is concerned, we have to do the surgery under general anesthesia. You need a good exposure of the anterior commissure. What then we do is de-epithelize, remove the epithelium from the upper to the lower lip, because it's not one line you're suturing, it's an area of the medial vibrating edge. We don't really excise the vocal ligament. We take 6-0 typically, vicryl. You can use permanent or absorbable. Typically, we've always been using absorbable sutures, vicryl, but you have to have it at least about 40 centimeters or 45 centimeters if you're going to suture outside of the scope. You need that much length. And after performing the suture, some people like to use fibrin glue on top of it. We typically do not. Some people also like to use hyaluronic acid injection to further approximate the vocal folds anteriorly. Again, we don't do that. But post-operatively, we give our patients 2 weeks of complete voice rest so that the sutures don't open up. And we give only intraoperative IV antibiotic. So this is a patient, for example, who's had a Wendler's glottoplasty, and you will see that there is an anterior glottic web. But at the same time, on the stroboscopy, the mucosal waves have a good amplitude. There's no phonatory gap. So you may question that sometimes if you see people with congenital web, how come they have so much hoarseness? And these patients don't have hoarseness because it has to be a very precise, only membranous vocal fold, edge-to-edge approximation, where the angle should be maintained such that there is no phonatory gap anteriorly. And this is just to show you the measurement from the vocal process to the starting of the web is equal to that to the anterior commissure. So that's 50%. And I'm just going to play maybe a 2 to 3 minute video, or edited video, of course, of a Wendler's glottoplasty being performed. So obviously these patients have a completely normal stroboscopy, and the pitch of these patients is typically 100 to 120 hertz when they come to you. So what we do is we will de-epithelize, remove all the epithelium from the anterior commissure to the mid-membranous point. How do we measure this? So the advantage when you use a laser is you can use this AccuBlade itself to do the measurement if you want. The other way of doing it is that you can actually measure the image on the TV screen and see what is 50%, or you can take an instrument and do it. I'm just giving a laryngeal wash now, which I typically use after laser, whenever I use the laser to remove the char. And now you see what we are doing is suturing the vocal folds. So you see over here, this is a 45 centimeter 6-0 vicryl being used, and the needle tip, it's important to know, this is a 8 millimeter needle tip with a 1/4 curve. And we take the suture through both the ligaments, as you saw, and we make the knot outside of the scope, and then with a knot slider, we slide it down. So when you do that initially, it will open up a little bit till your second knot comes over it. And typically we make 3 knots, and typically we make 2 to 3 sutures. Whatever is enough to get a good 50% web formation. So of course, we don't cut the threads very short even. So what happens with the absorbable sutures is that in about 8 weeks time to 12 weeks time, they absorb and there is no suture left. But some people like to use permanent sutures, which they have shown get embedded under the mucosa. So either way, it's no problem. You can do whichever way you like. There is also a possibility some people like to perform the suturing within the scope. And in that case, then you're leaving one end short and you're suturing within the scope. So whichever is easier for you. So what are the instruments you need for suturing? 2 instruments is what you need. Besides the scope, of course, and the microscope, you need to have a needle holder. So the needle holder has got a lock and ratchet system. So it can hold the needle tip firmly, and you need a knot slider. Some people manage to perform the suturing just with crocodile forceps, but very often the needle may slip. Some people also like to use a straight needle. So it's there's a lot of variability over here. You can get these sutures with a needle at either end. So you can use one needle from one side, other needle from the other side, and do both sides from in to up. So it really is what you finally find the simplest, because I'm not going to pretend that suturing in the larynx is easy. It's not easy, and one does need to practice. But because we are taking big bites into the ligament, it's a little bit, I think, easier than when you are suturing epithelium to epithelium. For example, if you're making a pocket in the epithelium for sulcus, putting fat and suturing epithelium to epithelium, that is definitely more challenging because the epithelium is thin, it tends to tear. So here we've taken our two sutures and you see a good 50% approximation. Some people would like to use fibrin glue, just squirt it over the suture site. Some people like to give the hyaluronic acid injection in the paraglottic space. Now this you can see when we've got the whole exposure of the membranous vocal fold, that it is 50%, because otherwise it looks very scary. Where is the patient going to breathe from? I'm going to just show you some voices of Wendler's. For example,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And now post-operatively. Wendler's glottoplasty. आपको कैसे लग रहा है आवाज?
सर्जरी करने के पहले मैं तो बिल्कुल भी हैप्पी नहीं थी मेरी वॉइस से, फर्स्ट ऑफ ऑल तो यही। और सर्जरी करने के बाद में मुझे खुद इतनी एक्सपेक्टेशन नहीं थी कि इतना जल्दी रिकवरी हो जाएगा और मेरा फुल्ली फीमेल का वॉइस आ जाएगा। ओके, बिकॉज डर तो बहुत ज्यादा बैठ ही गया था। करेक्ट। बट 3 वीक्स में ही मुझे बहुत ही अच्छा, मतलब 100% में से है ना, मतलब 98% मुझे रिजल्ट तो मिल ही चुका है। लवली, लव।
Another patient.
Start.
1, 2, 3, 4, 5, 6, 7, 8, 9.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Another patient, preoperative voice. You can hear the voices, huh?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now, these were all surgeries done with the laser.
2, 3, 4, 5, 6, 7, 8, 9, 10.
And let's hear some where we've used cold steel. The same surgery performed, but we used
1,
cold
2,
steel.
3, 4, 5, 6, 7, 8, 9, 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Start.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, so to do this surgery, the simulation and practice of suturing is something which would be important. So you can start first with a much bigger model and just take, any kind of gauze or tape, pretend that they're vocal folds, and practice the suturing technique by holding the needle at 90 degrees and practicing taking it from out to in to out, and doing the suturing. And then you can take maybe a porcine larynx or a goat larynx, and then actually practice on the vocal folds of the larynx if a human cadaver larynx is available. So this kind of practice can help you before you do the actual surgery. And then along with feminization laryngoplasty, you can also do what I mentioned earlier, the tracheal shave, which really should not be called a tracheal shave because you're not shaving the trachea. It's really a laryngochondroplasty, which basically what you're doing is you want the Adam's apple to be gone. So if you do, like I said, a cricothyroid approximation, it will further make it prominent. And what we want to do is we want to shave it down. So the main complication with this surgery is that if you shave it too much and you cut through the anterior commissure, the vocal folds will snap backward. So in this surgery, it's a very good idea to put one needle at the level of the vocal fold. Look endoscopically and put a needle in at the level of the vocal fold and then shave everything which is above it. So this is the surgery basically being performed to shave it down. But as you can see, this is the post-operative of the same patient. Small incision we take, expose the Adam's apple, have put that needle and shave everything or drill everything above it. Of course, like I said, every surgery is going to have pros and cons. So what are the advantages here? There's no neck scar. That's a huge advantage. Usually predictable results with a pitch increase. Again, a huge advantage. Operative time, relatively short. Depending on the more number of cases you do, it gets shorter. And then you can add on other surgeries at the same time, like the lava. And you can later on do various other surgeries like femlar or cricothyroid approximation if needed. The disadvantage is sometimes these stitches can give way, in which case the web will open up. Usually our problem is the opposite. A web forms and we don't want it to. Here you want the web to form, but it may open up. Also, if you incorrectly estimate, initially one tends to make smaller webs because you're a little bit worried. So that may then not cause the pitch increase which you want. Also, if you don't suture at the same level, there may be you may rotate the vibratory margin and that may cause hoarseness. So that becomes an issue then. Very occasionally, the pitch does not increase to the level you want, and the patient has to comply with 2 weeks of voice rest, which may be challenging sometimes, though these group of patients, they already know about it and they're very compliant with it in my experience. And finally, to talk about FEMLA, which is a surgery I don't do, but my colleague, Dr. James Thomas in Portland, has a great experience with it, where you're actually trying to make a male larynx into a female larynx. So imagine you're knocking out the anterior 4 to 6 millimeters of the cartilage, of the false cord, of the true cord, and you're resuturing everything together. So I want to show you his slides. This is Dr. James Thomas's slide. This is over here, the head end and the notch. So you expose the cartilage and then you're chopping 4 to 6 millimeters on either side. And not only you're making a cut, you're removing that cartilage. You've got the true vocal folds with that needle holder sort of thing. You cut the true vocal folds and the false vocal folds. You see the proline stitch through the true vocal folds and you resuture it and then you plate together the cartilage. When you do this, of course, polyps will form at the anterior commissure. You have to go back in again and remove those polyps. But you can have problems, other issues also, because it's an open surgery into the airway. So you can have infection as one of the problems too. The advantages are dramatic pitch increase. It shortens, tightens, thins the vocal folds. So you're acting at so many levels. He also couples it with a laryngeal elevation. So the resonance also improves and the thyroid prominence reduces because you're taking out the whole Adam's apple. The disadvantages are you're opening up the larynx. There can be infection. You may have to do a tracheostomy. Technically, very challenging surgery. Vocal fold resuturing may be done incorrectly. Then you can have permanent hoarseness. Healing time is much longer. Anterior commissure granulomas need to be removed. You can have a cut through of sutures. And it's a long surgery. And then finally, I just want to mention about voice modulation. Why do people not want it? The problem is that when they do voice modulation and they have to modulate the voice the whole day, you get exhausted at the end of the day. Also, one of my first vendor's patients said she was a beautician. She had her own beauty parlor. If she would cough or sneeze, that would be in a very masculine pitch. And then everyone would look at her as to what was that? So, you can't modulate your cough, your sneeze, or when you're angry also for that matter. So what we do with our patients, because they're not amenable to it before, once they've built a rapport with them after surgery and they've seen their pitch increase and voice getting more feminine, then we try to get the therapist in to work on intonation, breathiness, articulation, the word choice, which is different in females, the inflection, to get a more feminine quality of voice also. And that's when we see a complete metamorphosis. Though she looks like a woman, the trans woman, I think she really feels like one, and metamorphosizes completely when the voice becomes feminine. So it's such a joy to see that, and it's very gratifying surgery. So we had the second meeting of the International Association of Trans Voice Surgeons in Bombay Hospital just last year in November, and the third one is going to be in Seoul this year. And so, of course, everyone is welcome to come for it. You can check the website out. We also have our every year workshops in Bombay Hospital. So this year's workshop is going to be on the 30th of November with Dr. Simon Best from Johns Hopkins coming as a keynote speaker for the Dr. M.V. Kirtane oration. And these are my emails and contact information. And I'm very happy to take questions if it's permitted and if there's time. Thank you so much. I'll stop sharing my screen now.
Thank you so much, Dr. Nupur. I'm really mesmerized by your work. I'm sure everyone here has enjoyed your lecture and everyone feels the same.
Thank you.
Question for others ask, what is the general waiting period for a fellow to join you?
For the fellowships, the way I work actually is I ask the fellows to come and spend 2-3 days with me as an observer. And once they've spent that and their time and my time for the fellow, which is a 6-month fellowship meets, then we can go ahead. And typically it is variable from 6 months to 1 year. I have 2 fellows at a time. It's just at different times they join and leave, but at a given time, there are 2 fellows. This fellowship is then, the certificate is by Bombay Hospital and also by the Association of Phonosurgeons of India. So they get 2 certificates.
Wonderful. Thank you for the info.
I'm just going through the questions. Thank you so much for all the lovely comments. There is one question about, is it after post-op voice therapy for the voices I showed? Yes, that is correct. So typically after 2 weeks, we do start some voice therapy and the voice modulation. And most of these voices are at around 4 weeks to 6 weeks. This group of patients are not people who keep coming for follow-up. They don't want to meet you again, typically. So we have our follow-up at around 6 weeks. But now I've started getting patients who come with family members sometimes. There was a trans woman who came with her husband also. So the pattern is a little bit changing for the better, because I can see that they're getting more socially accepted. Is there any airway embarrassment? If we stick to 50% of the membranous vocal fold, not at all, not even dyspnea on exertion, because as we know, 75% of our respiration takes place from the cartilaginous larynx. So that is intact, and we have 50% of membranous. So no airway embarrassment happens. And so the restrictions for physical activity post-surgery are definitely there. For 1 month, we don't want very heavy weights to be lifted at all. Anything which is going to cause too much of subglottic pressure, we don't want, because that may cause the sutures to give way. But after 1 month, and once the web is well formed, then all kinds of activity is permitted. So to be honest with you, the cold steel, to answer this question about did you find any difference in the post-op voice between cold and laser assisted, I can't give a very correct, educated answer on that, because all the cases, 4 or 5 I did with cold steel, were in Pondicherry in a workshop they had when they were setting up their trans voice program. So it was a different microscope. It was a different setup. Obviously one is most comfortable in one's own setup. So I would want to do the cold steel in my own setup. And I do feel there will be no difference if I do it in my own setup, whether with cold steel or laser, because it's just a tool which is making it raw. So I don't think there would be different outcomes. Is extubation not a problem? Immediate post-op? No, in all MLS surgeries, we're typically using a 5 or a 5.5 number tube. Those are very small tubes. We deflate the cuff completely, and there's more than enough space for the tube to be removed under vision carefully. The suture material, as I mentioned, I'm using 60 Vicryl, where the needle tip is 8 millimeters and 1/4 curve. But some surgeons like to use Prolene, permanent suture material. So that's your choice. Regarding the recurrence, I suppose what we mean is if the web opens up. In the last 15 years, it's happened in one patient of mine where the web opened up, but the patient was not very unhappy with the voice, so they didn't go in for a rewebbing surgery. But of course, one can go ahead and again web. It's a question which you ask is very good question, Dr. Navneeta, that is it reversible in future? Because now there is this concept also that, like, let's say there's a trans woman, but they may sometimes change their mind and want to go back. So then what do we do about the voice? And so as we know, web, when it's formed, to remove the web is a bit challenging, but it can be done. So what we do for when there is this kind of a clean web is we make a cut, a butterfly surgery it's called. We make a cut on any one side of the vocal fold and elevate half thickness epithelium and then cut on the other vocal fold so that we have two flaps and we suture it like this and like this so that we epithelize both the sides. It's called a butterfly surgery. If we can't manage to get two flaps, then at least one side we suture it. So that's what we can do for reversible. So it would be a surgical reversal, not medical. Also, to answer Dr. Chanchal's question, what's your experience with pubophonia? I have a patient with pubophonia and posterior phonatory gap. So when it is pubophonia, I would like to know the age of the patient, because if it's someone who is 20, 21, definitely therapy, speech therapy is the correct thing. But sometimes you have patients who are like 27, 28, 35, then they're not compliant. I mean, they may do better with therapy when the therapist is there, but then in the real life situation, the pitch again goes up. So of course, the type 3 laryngeal framework surgery is an excellent surgery. It gives amazing dramatic results, very easy surgery to do. So in fact, the tendency is to jump into that surgery, but if the person is young, we should do therapy because 95% will improve. Just want to mention, always do the Gutzman maneuver. If the Gutzman maneuver, which means take the larynx down and posteriorly, is positive, that means when you do that, the pitch drops, then you can be quite rest assured that your type 3 surgery will have very good outcomes. Though pitch changes, but voice looks husky. If you're talking about the patients, one or two of them, yes, there was one patient especially who went into a very breathy kind of a voice. In fact, it was very breathy initially. That was one of the patients we did in Pondicherry. And that can happen when there is an anterior phonatory gap, like a keyhole anterior gap, which you have to work then with therapy. And sometimes it may require another surgery to make that angle acute and not like a keyhole. Till now, most patients have improved. Nobody has been left with too breathy a voice. And in women, sometimes a little bit of breathiness is considered desirable. So some patients are quite happy with it. So it depends on whether they are happy or not with it. And future general surgeries, Dr. Dilpreet, very good question. We always give a little note or a card to the patient that for any general anesthesia, go with at least one size smaller. In India, I would say 2 sizes smaller because typically people tend to use 8 number for males, whereas 7 is more than enough. So, one should go with a 6 number tube for these group of patients. So one size smaller. Yes, that is important. Then the question from Dr. Kamalika is whether we need to counsel patients regarding tracheostomy and MLS surgery. This was suggested by anesthetists, but I'd like your opinion. So the thing is that routine MLS surgery, we do not take tracheostomy consent. But if there is some kind of bilateral immobile vocal fold or subglottic stenosis or a very large tumor, then we take tracheostomy consent. So not for routine MLS, we typically don't. Now the AOI has come up with AOI consent forms actually for every surgery, including MLS. So maybe you would like to use those because then one can always say this is the consent form of our national body. It's a pretty thorough consent. They have patient information forms also. I know Dr. Kaushal has shared it, I think, on many groups. So maybe that's something you can think about using? I think I've answered most of the questions.
Yes. Ma'am, you're fabulous. Nobody wants you to stop talking. When you're talking, everyone is listening spellbound. The questions are coming, the answers are coming. It's like a lovely interactive session. So much to learn from you.
Thank you.
Thank you so much for agreeing to come, ma'am. I think this is like one of the best attended Zoom meetings. Started dot on time,
Thanks.
very good attendance, and lots to learn. So, ma'am, I request you to stay on because there are two PGs from AIMS Bhubaneswar, really bright, enthusiastic, cute girls, Dr. Anjana and Dr. Safia. And I'll request them to share their screen. They have prepared an ENT crossword. So they'll just show how to play that crossword. And once they'll show how it's done, and then there'll be a mind bender crossword for all the participants. And then there's an attractive prize for whoever does it the fastest and the most correct. So Dr. Anjana and Dr. Safia, ma'am, I request you to please stay, and doesn't matter whether you're a resident or a consultant, it's fun for everybody. And there are some clues from this lecture also. So you'll at least get one answer right. Of that, I'm sure.
I just want to say thank you very much. And I'm going to be staying on, but I just want to thank you very much. It was indeed an honor and a pleasure.
Thank you, ma'am.
Thank you.
So Anjana and Safia, please unmute yourself and share your screen. And I request, I'm putting out my phone number on the Zoom chat window, because everybody who solves it has to send it so that with your name, so that we know who answers it correctly and the fastest. Okay. So over to the both of you.
Thank you, ma'am. So we welcome you all to the first WAOI's Mind Bender. It's a ENT-based crossword puzzle. I'm Dr. Anjana and
Myself, Dr. Safia.
And we are junior residents from AIMS Bhubaneswar.
So basically,
So we wanted to make the idea of learning to be fun. We didn't want anyone to feel afraid when they are seeing a new question. So that is why when we got this idea by around mid-January, we spoke about it to Ashima ma'am, and ma'am was so supportive, and thus this evening has come into a manifestation. So thank you, Ashima ma'am, for the great idea and the platform to perform.
So basically, we'll be having a crossword puzzle which will have 16 questions in it. It will be just like any other crossword which you find in the newspaper, but the clues will be related to questions which you generally are asked in the daily morning rounds or which you have read at some point in your ENT life. The only difference is we'll be doing it live here. So we'll be sharing a link which will lead you to a website where you can solve it live. We will be giving you around 10 minutes within which we expect you to solve as much as possible and forward the screenshots of your answers, whether you have completed fully or partially. Please send your screenshots with your name and place to the number provided. And after that, we'll be discussing the answers. So first we will proceed with a short demo so that you get to know like how to solve the clues.
So Safia will be reading the questions and I will show you how the answers will be when we solve it.
Here, one across. Can you all see the screen?
Yes, we can see your screen.
Okay, so
one across
this is something like this, but here we have given just 5 questions, straightforward questions. So one across here, we have the flamingo pink sign of tympanic membrane seen in the active stage of. So when we click on that, you can see that it is highlighted. You can just try typing whatever you feel like.
If your answer is right, you will get it green. But suppose if you change the spelling in between, suppose if you change it to like, it will still remain blue. Okay. The second question is,
one down is calcium carbonate crystals in inner ear responsible for BPPV.
so the answer is otoconia. But if you're like say in doubt whether it could be an otolith or something, this is what will happen. It will still be purple. So you can change it. And once you get the correct answer, it will turn green in color. So if not, you should check on your spellings or check whether your answer is right. Okay. So quickly to go through the other, the second two down is the anterior inferior area of the nasal septum, which is the litmus area. In our puzzle, we have not included the apostrophe S.
If
This
it
is
is gustatory sweating as a complication of parotid surgery, though we generally say phrase, we have avoided the S. This was applicable for the main quiz also. Intrinsic laryngeal muscle supplied by external branch of superior laryngeal nerve.
So once you're done with the entire quiz, with the entire crossword, please take a screenshot of it and send it to the number which will display on the screen. Is everyone clear with it?
Yeah, I think we can post it.
Proceed with the final.
Yeah.
Okay, so we have we'll start.
Can you share the link? So we have shared the link for all of you. Can you also open the puzzle on the screen
Okay.
for people to see?
Okay.
You have 10 minutes of time. Have you started with the time, ma'am?
Yes, so we have time. You guys can start reading out the clues.
Okay.
Give some hints if you want to. And I will let you know as soon as the answers start pouring in.
So the first question in down talks about the part of the nose which A in Char syndrome affects. So it's an anatomical question. It depends on your knowledge on what are the parts of the nose. This I'm pretty sure everyone should be aware of currently after the session today. So this is a part of ENT and skull base where we are talking about one posterior medial triangle in the middle cranial fossa that borders the petrous apex. So when we drill through this triangle, we can enter into the petrous apex. Six down is the vomeronasal organ for detecting pheromones. It is a name of a person. It is named after the person who discovered this region. It is seen as a slit in the anterior rhinoscopy. This is a fairly straightforward question. It's asking about the name of the cartilage or the second pharyngeal arch. The incision used in thyroidectomy, also named after the father of thyroid surgeries. So this is a new age or a novel laser surgery which we used for vocal sulcus. So at the 5th minute, we will give the starting alphabet for 2 of our questions. At the 7th minute, we will give the starting alphabet for 2 further questions. At the 9th minute, we will give the starting 2 further questions. So we will make it like 6 questions. We can give you a small clue. So this is a radiological plane where it's a very posh plane, and it is used to visualize the superior semicircular canal dehiscence. At one cut, it can also give us the entire vestibular aqueduct too. So 2 across is a syndrome where you have both sensory neural hearing loss and retinitis pigmentosa. 5 across is also a syndrome where you have anosmia and hypogonadism. This is a physiological anastomosis between the external and the recurrent laryngeal nerve. In the external, it is the dorsal branch of the internal laryngeal nerve. So the anastomosis is between the dorsal branch of the internal laryngeal nerve and the recurrent laryngeal nerve. So this is the criteria for congenital cholesteatoma. A hint for this is that the criteria also shares the name with the same criteria which is used for skull-base osteomyelitis. Supraclavicular triangle, which is usually seen in nasopharyngeal malignancies N3B stage. Nystagmus, which we see in acoustic neuroma. The name. This is an instrument. It is a knot tire which is used to secure the knots in tonsillectomy bleeds. And this is a very interesting question. The name is common, but it is found it's found in ear, nose, as well as larynx. In the ear, it's a fissure. In the nose, it's a bone. And in the larynx, it's a cartilage.
So now Anjana and Safia, you have to give some starting letters. So you print them here so that people can start. They have
So
some.
the posterior medial triangle in the middle cranial fossa starts with K. And the 45-degree oblique view of the HRCT starts with P.
Can you give 2 more hints, but give them for the for some crossover words where 2 hints are covered.
Okay.
The answers have started pouring in.
Yes. Yes. H. Ma'am, how good are we in time?
We are very good in time. I think in the next 2 minutes, we have to ask whoever has solved however much to please start sending. So in the next 2 minutes, just click a screenshot of however much you have been able to solve. And I think after 2 minutes, we will want you to start giving the answers. I'll tell you when.
Okay, ma'am. So it's nice to see such concentrated faces.
Okay, 1 second.
Shall we go with the last clue, ma'am?
I think one hint you can give, no? Most difficult one.
One more hint? Okay.
No, solve one for everybody.
Solve one.
Yeah, I think you should solve number 15. It's hard.
Number 15. Acha.
First letter. No. It's not
The first letter we'll give, ma'am.
You are very strict examiners.
Okay, we will give you the first two letters.
Okay.
This was actually a very interesting question. It was one of the first questions which was asked to us in our daily rounds. And we were also like clueless at that time. We learned it the hard way after we got scolded. So we are making it fun for you.
Okay, so at 8 o'clock sharp, everybody just send however much you have solved, and at 8 o'clock you will start giving us the answers. Take 5 minutes to take the answers, and then we will request the executive to announce the results. So everybody please share your screenshots with me. कपड़े बच्चे को बस ऐसे हाथ में हे कुपन येतं तेवढं हे कुपन दे का तुझा Anjana and Anjana and Safia, please share the answers. Please solve
Okay,
it.
ma'am.
Yes. One of you solve it, one of you prepare the result.
Actually, we already.
No, just continue. Just continue.
Okay. So this is the final answer key. Congratulations to all who have got it.
Yeah, so read out the question and the answer. Yeah.
So the first, so we have one answer as Usher syndrome. It's a syndrome which has both sensorineural hearing loss and retinitis pigmentosa. It's an autosomal recessive disorder, and actually it has three types: 1, 2, and 3. 1 is when you have severe to profound sensorineural hearing loss in a newborn infant, along with a vestibular imbalance, and retinitis pigmentosa develops in childhood. 2 is when you have moderate to severe sensorineural hearing loss in infancy, but the vestibular system is normal. And 3 is when you develop sensorineural hearing loss, either moderate or severe or profound, at at childhood with a normal vestibular system. For all three types, you have retinitis pigmentosa, which develops in the later part of childhood. Treatment is actually cochlear implantation. For type 2, we can also go for hearing aids as moderate to severe type of SNHL. Some children can respond well. For the retinitis pigmentosa part, vitamin A therapy is usually preferred. And this is the 15th question, the Santorini. The fissure of Santorini, which you see in the cartilaginous part of the EAC. The Santorini or the corniculate cartilage, which develops from the fourth pharyngeal arch. The superior concha is also known as the the bone of Santorini. So this is Santorini in ENT. The Neger's knot tire. You would have seen, I think so, Nupur ma'am had also used this only to take her knots in. I'm not sure. So this is used to adjust or tighten the suture knots over the tonsillar fossa bleeder. And the tip of the instrument is usually used to push the knot till the end. And it can reach the bleeding point. So this is the Neger's knot tire. The Gallen's anastomosis. It's the anastomosis between the dorsal branch of the internal laryngeal nerve and the recurrent laryngeal nerve. It is said to be the nerve plexus of the vocal cord. The Jacobson organ. It is a vomeronasal organ. It is seen as two pits on both sides of the nasal septum, just anteromedial to the inferior turbinate. It detects pheromones, and it sends the nerve fibers from the Jacobson's organ goes not only to the olfactory bulb but also goes up to the limbic system. So that is the Jacobson's organ or the vomeronasal organ. Kocha's incision. It is a curvilinear incision 2 finger breadths above the sternal notch. It extends between the anterior borders of bilateral sternocleidomastoid. This is for a normal total thyroidectomy. But if we also want to do a lateral neck dissection, we will do a modified Kocher's incision where we extend the required side till the posterior border of the sternocleidomastoid. So that is Kocher's incision. This is the Bruns nystagmus. So it's a nystagmus which you see in large cerebellopontine angle tumors. So if your eye is facing towards the side of the lesion, you have a high amplitude, low oscillatory frequency, horizontal jerk type nystagmus. If it faces away from the side of the lesion, you have a low amplitude, high frequency horizontal nystagmus. You can see that in the video. This is the affected side. Okay. Wendler's glottoplasty. I don't think I have to add more to this. I am pretty sure everyone got this right. Hopefully. The novel laser surgery used in vocal cord sulcus is the LASR. So before I explain these two pictures, the credit goes to Nupur ma'am, and we got the screenshot from ma'am's video in YouTube. So the classification of type A, type D also I am taking from Nupur ma'am's classification only. So you use a carbon dioxide laser in the scanning mode with an acute blade with a length of 0.3 to 0.5 millimeter and a depth of 1 millimeter using a 250 micron, and cuts are made at 90 degrees to the lips of the vocal sulcus. We make sure that we do not enter into the anterior commissure. So the advantage of this is that secondary epithelialization which occurs post this does not cause furrowing. A type A sulcus is any sulcus which involves more than 50% of the length of the membranous vocal cord with a depth not extending beyond the SLP and the superior lamina propria. Type D sulcus or a focal pit is anything which is any sulcus which is less than 50% or less than half of the membranous vocal cord's length, with the depth extending only till the superior lamina propria. So these are the laser cuts which you see. Can you see my arrow points here? So the cuts are made at the lips of the vocal sulcus at a 90-degree angle or perpendicular to it. This is a live photo in ma'am's video. I would recommend you all to see this video. It's really nice. Thank you, Nupur ma'am. The right shirt cartilage is the name of the second pharyngeal arch. So a small clue and find like remembering the derivatives of this is that all its derivatives starts with the alphabet S. You have the stapes suprastructure, the styloid process, the stylohyoid ligament, the smaller or the lesser horn of the hyoid, and the superior part of the body of the hyoid. So this is the right shirt cartilage and its contents. Kalman syndrome. So this is an autosomal dominant disorder where you have anosmia or hyposmia and hypogonadism. So there is a defect in the KIS1 gene which gives rise to the KIS-peptin protein. So this protein helps in maturation and differentiation of certain neurons present in the which developed in the olfactory epithelium, and from this region it should usually migrate to the hypothalamus, and this will help in producing the GnRH which is absent in this patient. There is an old school thought which states that cranial nerve 0 or the terminal nerve is this nerve which carries nerve fibers from the olfactory epithelium to the hypothalamus. The Kawase triangle or the posterior-medial triangle. So this is bounded by the petrous ridge as a base, the greater superficial petrosal nerve posterior laterally, and the arcuate eminence posterior medially. So when we are accessing the petrous apex or the clival part of the skull base, this triangle is usually preferred because it is an avascular zone and you usually do not encounter any neurovascular structure here. Anteromedial triangle, also known as the Mullen's triangle, is usually used by the neurosurgeons to enter into the retrosigmoid approach of the cavernous sinus. So this is the Kawase triangle. The host triangle or the supraclavicular triangle, bounded by both ends of your clavicle and the uppermost part of your junction of your shoulder blades and your neck. So any lymph node which is present over here in the nasopharyngeal malignancy carcinoma case becomes an N3B lymph node. Treatment is with radiotherapy. The postural view. So it is a plane of projection that in the temporal bone that is perpendicular to the axis, or we can also say that it is a 45-degree oblique view. So in this, you can see the complete superior semicircular canal. If there is any dehiscence, we will be able to see this. If you can follow my arrow, this is one cut where you can see a partial shadow of the vestibular aqueduct. In the subsequent cuts, we can see the entire vestibular aqueduct clearly. The normal diameter of this is between 0.3 to 0.5. If we have any diameter of the vestibular aqueduct that is more than 1.5 millimeter, as seen in the postural view clearly, it is known as an enlarged vestibular aqueduct. So the A in the Chart syndrome, which stands for atresia of Coena, affects the choana in the nasal cavity. So C is coloboma. H is heart defects, which are usually ventricular septal defects. A is the atresia of Coena. As you can see here in the left nasal cavity, you have a choanal atresia unilateral. R is growth retardation. G is genital abnormalities. And E are ear anomalies. So this is the A of Chart syndrome. Now coming to the last question, the Levinson's criteria is the criteria for congenital cholesteatoma. So the 5 points which you have in this criteria is that you have a white mass which is medial to a normal tympanic membrane. There is a normal pars placida and pars tensa. There is no prior history of otorrhea or perforations and no prior otological procedures. Prior bouts of otitis media were not grounds for exclusion, as was the case in the original definition given by Mackenzie and Derlaki. So, a fun fact, the recurrent laryngeal nerve is the longest nerve which you see in a giraffe. So, at the end of this, I would really like to thank Kalpana ma'am for this wonderful platform, WAOI. Thank you, ma'am. And thank you for all those who have participated. I hope you have learned something new. This is our small help in enabling your learning. Thank you.
You're very welcome, and thank you, my dear children. I mean, both of you have done fantastic. Why don't you come for the midterm conference and have more crossword puzzles there? We'll all look forward to it.
We'll try, ma'am, for sure.
Planning on it, ma'am.
Good luck.
So, ma'am, we have our winners. I would invite Sharmila ma'am, our vice president, to please announce the winners and the names of all the participants who have attempted.
It's been a great pleasure to attend this crossword puzzle with all ENT facts. I remember, I think all of us must have had immense pleasure in solving crossword puzzles right from childhood, going from simple ones to more complicated ones. And this was a very different idea, very well appreciated. A crossword puzzle with ENT facts, including the excellent presentation of the answers, solutions, done so interestingly. So I would like to thank Dr. Anjana and Dr. Safia for preparing the crossword puzzle and presenting it so well to us at WAI for this event today.
Thank you, ma'am.
Yeah, and the winners are Dr. Anubhuti Dhanuka, Junior Consultant at Chikitsa ENT Hospital, Amritsar, first prize. Dr. Tanmay Kataria, who is an Assistant Professor at Mahatma Gandhi Hospital, Jaipur, second prize. And Dr. Dilpreet, Consultant at Artemis Hospital, third prize. So it's a great privilege to announce the winners. And I would like to congratulate all of them for their knowledge and getting the prize. The speed also, because the speed also counted. And of course, if you don't have participants, then the quiz really does not have any meaning. So the crossword puzzle. So I would like to announce the names of all those who participated for giving competition and for us to get the winners from among them. So all the participants, I would name just in any order, random order. Dr. Payal, Dr. Grace, Dr. Suhema, Dr. Avani, Dr. Irene, Dr. Pallavi, Dr. Richa, Dr. Nimisha, Dr. Kanchan, Dr. Pujita, Dr. Kalpana, Dr. Ritika, Dr. Sulbha, Dr. Sonam, Dr. Sushma. I hope I not left out anyone. And it's been a real pleasure. Seeing this event and the crossword, announcing the winners, a wonderful event. I'm sure all of you have learned a lot also from it. Networking and mentoring is our mission and vision for WAI. And every event just takes us one step further in achieving what we wanted to achieve.
Thank you so much, ma'am. So I'll request Ava ma'am to give a small vote of thanks and Kalpana ma'am to invite everybody for the midterm conference.
Yeah, Dr. Abba, you first.
Hello, good evening. It was a very, very nice lecture by Dr. Nupur, and quiz was very good. I could solve only two. One was the Dr. Nupur's stitches, that Wendler's and Santorini. The rest was very difficult, but I am really enlightened. And I would like to thank you all for participation and participants. Thank you.
Hi all. Yeah, as president of WAI, I would like to invite you to the midterm conference that is happening on 10th March. It is at our hospital, Apollo Hospital, Indraprastha Apollo Hospital, New Delhi. So it will be within the auditorium there. And we're expecting large audience. Actually, our aim is to have interactive sessions so that each one of you benefits. And we're going to focus on, fellowship programs, how to go about it, how to apply, where all can you go, and what is the waiting period. We'll give you all the details so that it's, we can guide you to take up these fellowships in future. And I look forward to really seeing each one of you. I'm telling, we're promising that it's going to be a fantastic session. It has also DMC credit hours, 6 credit hours. We're hoping to get 8, but so far it is 6. And what else, Ashima, am missing? There are free paper sessions. There would be awards for that. And we also would be having a small, 15-minute session for quiz. And the fun part, I'm not going to disclose anything. We're going to have a celebrity, and we would definitely have a fun-filled evening. So the entertainment could include everything. It could be dancing, fashion show, etc. That's for the evening. And morning, it's going to be a total academic feast. And hope to see you all. We extend this warm invitation to each one of you.
Thank you, ma'am.
Do come.
So we'll take your leave. Thank you very much. We'll close this meeting and post the results on the WhatsApp group. Also request everyone to post your comments on the group so that more people are encouraged to join with every progressive online event. Thank you so much.
Thank you, Ashima. Thank you, everyone.